thanks so much. Just to get to share some things with you that I'm passionate about, and taking your time out on a Saturday. Also, it's very unnatural to be talked at or talked to. So please, if you have any questions, please interrupt me, let me know, and we'll have time at the end as well. So I don't have any interest, financial interest or otherwise, in this talk and anything I'm going to talk about. I'm not getting paid to do it. But I also have to say that the title of this talk is not completely true. It's kind of just something to grab your attention. But there is a lot of truth in it. I set some goals for today. So one is I'd like to talk about what is cardiovascular disease. So do we have any, actually I know many of you guys, some of you guys, who's not in a medically related profession? Excellent, all right, awesome. So we'll talk about what is cardiovascular disease, what causes it, how it's treated, who treats it, and how can we be better? Because that's what we're kind of always striving for. And again, I want to answer your questions. I want us to learn from each other, and I want us to have fun. So what's cardiovascular disease? So it's a very broad term and a lot of things. So you may hear about aneurysms. You may hear about heart disease, valvular disease, cardiomyopathy is when the heart doesn't beat very well, abnormal rhythms. Some of these things people are born with, congenital diseases. Carditis, they could be some kind of inflammation or infection. And then I'm sure you guys have heard of blood clots, both arterial and venous clots. But today, what we really want to focus on is arteriosclerosis or atherosclerosis. And these are the plaques, the hardening of the arteries you may have heard of that occur in our arteries and basically cause heart attacks or what we call MIs, strokes. They can cause blockages to your bowels, kidney, and your liver. And they can cause a lack of blood flow usually to the legs, sometimes to the arms. The arms tolerate it a little bit better. This is the leading cause of death in just about every region of the world. Cholesterol, esters in the arterial wall, they form these complex plaques. I mean, I'm skimming over some things here that are actually pretty complicated, but for our purposes, that's basically what it is. They're insidious, so they start really when you're young, before you even know it, and they span over decades. But then the clinical consequence of these traffic jams of blood flow happen within minutes. And so you've all heard of the people who get this sudden onset of chest pain or have a stroke or have what we call a cold leg from those plaques traveling downstream. Now, the interesting thing, given the way medical care is, at least in the United States and other countries, is that even though this is the leading cause of death, people are living longer with it. Although in the last year, we've seen actually that lifespan is going down a little bit in the United States, especially in certain age. But the age-specific death rates from this are actually decreasing. So there's an increased prevalence. So there's more of it out there. And there is clearly a financial burden. And I'm sure if you guys watch the news or read the news or however you get your information, you know that many Americans are afflicted with this, and the cost is tremendous. We'll come back to this slide later, and I know Pete sent it out on social media. That's from 2013. The numbers for 2019 aren't in just yet, but you can see as a percentage of the gross domestic product, it is about almost 20%. It has been stable since the late 2000s, but we are way ahead of other countries in that regard. So what causes it? So I said that it's all lifestyle in my title. It's not really true. So this is a study of the Horus study. Horus was an Egyptian god, and they gave it this cute name. But basically, these group of researchers, they looked at mummies, and they looked for atherosclerosis in these mummies, and they compared it to in the same population. I'm sure things have probably changed over thousands of years in the Egyptian region, the Egyptian population, but it basically showed that this existed thousands of years ago. So it's hard to read, but it's about 40% of mummies and about 60% of modern patients. So a little bit higher today, but it wasn't completely non-existent thousands of years ago. This is a more recent article from JAMA Cardiology, where they actually looked at just a handful of individuals who ate a fish-based diet. They're an Inuit population in the Arctic, and even though they ate this fish-based diet which we often, and lived in this sort of natural way, they still had atherosclerosis. Now, they also kind of theorized that they may have had a lot of smoke exposure from the way that they cooked the food and the way that they had to keep warm living in this kind of climate. So maybe that had something to do with it. And then one other study I just wanted to bring out of the Lancet Journal, which is another very well-circulated journal, is this coronary atherosclerosis in an indigenous South American population was actually very small. So they're a little bit different. They don't live around fire as much, maybe less smoke. They kind of hunt and gather all of their food, and they had a very, very low rate of coronary atherosclerosis.
Have they ever seen this like in chimps or gorillas or any of our ancestors that way?
Yeah, good question. It does occur, but not to the same degree. So there probably is. It's like everything. There's just no sort of one cause. I think the baseline exists, and that's a great question. The baseline to form this exists, and then it's kind of the things that we pile on top of that.
I think that's a really good point, because we're looking at cross-sectional studies, right?
Yeah.
So they can't prove anything, really. We're looking at associations.
Right.
So I think that there's several jumps in logic that we have to make to say that arteriosclerosis or diet or whatever causes heart attacks, right? So we have to assume that what we eat causes atherosclerosis, that atherosclerosis itself causes heart attacks. And those jumps in logic are actually founded on data that is murky at best.
Right. It's hard. We basically do the best with what we have.
Exactly.
But it's interesting to see, right, that we often, we have this idea about the way we live in modern lifestyle, and it's not, and we probably think it's not always the greatest.
Yeah.
But it was occurring thousands of years ago, which is very, very interesting. Yeah.
Yeah, and part of it could just be also mechanical, right? I mean, like things flowing through narrow tubes, like just, like our cardiovascular system versus a central heart beating, whatever kind of animal.
Right. Well,
right?
That's you. I think you stole my slide. Coming up, because that's actually what I was going to talk about here. So I don't have any engineering or any engineers or flow specialists here. So that's one of the other theories, that we don't know for sure, but all around our body we have these bifurcations of blood vessels. So this is a drawing of carotid artery. So the carotid artery comes up off the aortic arch and it splits into one that feeds the face and another one that feeds your brain. Some percentage of strokes we do know actually come from the disease there. Maybe about 30 to 40% actually come from the carotid artery. And plaques form here. And we don't know why in some people more than others. And we don't know why on one side versus the other. But plaque tends to form here, and we think it's because of the shear wall stress and how things are, you don't always have what we call laminar flow, where everything is flowing nicely alongside of each other. And this is, you've seen an ultrasound, which there's a couple different ways that ultrasound works. This is one where they use color to talk about flow. So the more you are from the red to the yellow is a flow in one direction, and into the blue is a flow in another direction. So you can see here, this is flow coming forward from the common carotid into those two that I talked about. But then you see a different colored blue, and you also start to see it coming up where the branches are. So what you're basically seeing, this is just another representation of the same thing. Flow is going this way and then going in reverse in these other directions. And that may also have something to do with it, and may be why this is something that we're just going to be inflicted with as human beings, and clearly we're not going to live forever. This is an article from Circulation about 10 years ago, and the whole point of this study was basically they're just looking at autopsies in young people and showing that we know we're going to have this baseline problem with atherosclerosis probably down the line, and the earlier in life that we start doing what we think are the bad things, the more accumulation of this disease we're going to have. So the biggest issue that we face in what I do for a living is tobacco. Now the rates have gone down overall, they've gone up in other populations, but this is pretty much the worst thing you can put in your body in any sort of way, whether it's chew, smoke, etc. outside of all the cancers that it causes, and it is almost associated with every cancer you can think of, this is just horrific for your blood vessels. Even if it's not causing atherosclerosis, it actually causes blood clots. It causes inflammation on the walls of your arteries. I actually, unfortunately, I did something yesterday to a patient who didn't have any blockages anywhere, but his femoral arteries, where we had to go in with a stent, were so inflamed, and the intima, which is the inner layer, was so thick and this is really all from smoking, that it was actually pretty hard to actually fix it and put it back together. As you know, we've seen a lot about sedentary lifestyle recently, and these are some of the things, again, like Danny's saying, we don't know causation, correlation, but we think it has something to do with it, not just the way we hang out at home, but the way we work, on a day-to-day basis. A lot of us are sitting around in front of a computer. These are not pictures from Google. These are actually pictures that I took with my own camera, and I walk into my office. You've probably seen this. And everybody has a birthday every day. Or something. Or they're going away. I mean, these last two were from this week.
Oh my God.
Do I want to have a bite of this when I'm hungry and tired and stressed out? Yes. I'm being particularly good this month because I really need to get back after the holidays. But, when you're inundated with this on a daily basis, it makes it pretty hard, and you really have to plan ahead. Now, what's even more distressing is when I would go up and I round on the floors with my patients, and I see that my diabetic, atherosclerotic patients are getting this, and the things that we don't give them in the hospital, someone's bringing them Gatorade and 7-Up. It's just, it's a little disheartening, to be honest. And here's, the order sheet, but at least the yogurt is light, if you can't read that. It's probably not light on the sugar. So we kind of alluded to it before, it's all this, the way I see it from what I can tell, and what I think most people think is, we're all heading to some endpoint. We're all likely going to have some kind of issue, and whether it's just breakdown of age over time, but we need to do some things to mitigate, to step back, to not pile on the issues that we may end up with in the end anyway. And that's where sort of lifestyle and diet and all that comes in. So, this disproportionately impacts minorities and low to middle income of any racial or ethnic background. A lot of that has to do probably with some amount of education, with access to care, with access to, bad food is cheap, honestly. At least that's how the setup is here in this country. And, we basically talked about all of these things. So I hope, I try not to show you too much of the gross pictures, but I think just to give you an idea of kind of what things look like. This one, I think my iPhone at the time was on Fritz, so I got a grainy picture here, but this is what a nice vessel should look like here and here. And this is all the, plaque and atherosclerosis is a combination of this cholesterol on the wall, platelet deposits, and inflammation, fracture. This is not a vessel. This is what was all inside of a vessel that was all taken out. And then
is that a solid? That's like a solid piece of.
Yeah. So it comes, and sometimes it gets more calcified than others. So here it's a little hard to see, but here's a more calcified segment. This is almost more like the person who's purely afflicted by the smoking issue. So you get that solid, inflamed, just like a cast of the artery. The problem too is when you take this out, you then set off your own sort of chain reaction of inflammation in the vessel. So it looks beautiful when you're done, and you sometimes need to do that because you've reached the point where you're in a life or limb-threatening problem. But then you have something that's called intimal hyperplasia. So to make a long story short, it's just that everything gets, just like if you cut yourself in your skin, you're going to get inflamed in order for it to heal. So it does that to try to heal, but in the process of doing that, it starts to stricture that artery back down again.
So do you put in another piece of, for lack of a better word, pipe to fill that void, or do you pull that out and let the old one work smoothly? Is it like unclogging a drain, or is it replacing the drain?
Now, what we found actually works. The best thing you could use is someone's own vein to actually, once you take this out and you get good endpoints, you actually sew a patch of vein onto here. We also use bovine pericardium, so covering up the cow's heart that's purified. That works pretty well. And we sew that in certain areas like the groins and the femoral arteries and the carotids. That actually works pretty well. The aorta, we oftentimes replace it. And then in other arteries, you can stent, although I have a few numbers on that to just show how good or bad that can be. And then there's a lot of other things that, that also contribute. We're not going to get into today, but air pollution, heavy metals, other organic pollutants. How's that affecting, what happens to us? I'm not an expert in that area, and I don't know exactly, what the latest thinking on that is, but I have my suspicions about those things and what they may cause. So, how is it treated and who treats it? So, we could spend days talking about all this stuff, but I want to just focus on limb ischemia because I think it's actually not the biggest part of my practice. It is a part of my practice. I deal with a lot of different things. I deal with a lot of aneurysms, a lot of carotid disease, but limb ischemia I think is very, very interesting, and I'll show you why. So these are the people who, your primary provider is, sort of the first person, cardiologist, cardiac surgeon, the vascular surgeon, in some way, shape, or form. As specialists, your primary doctor is dealing with all these things, and we as specialists are dealing with some portion of these things, as I mentioned. But I also submit to you, as many of you guys know, your coach, your trainer here at the gym, and you yourself are the people who are going to treat this on a daily basis. We can sit with you for 15 to 30 minutes or whatever time we have, and God knows they want us to see more people. And it's needed, but we can only, you can only do so much. A lot of it has to go into your home and things that you need to do if you want to live a healthy life. If you want to live, you may live the same amount of time as everybody else, but it may just be not the greatest quality of life. So what do I do as a vascular surgeon, in case you're wondering? Actually, of all the surgical specialties, we do a fair amount more than just surgery. We have a lot of patients that we see on a regular basis who we've never operated on or we may have operated on, and we continue to follow them. We build relationships with them. We treat them for a long time. Pete sent this out as well. So this is just our society's website, and I'm proud to say it's not the most popular saying within modern medicine these days, but I am very happy to see on our website that it says that many of our vascular problems can be treated with exercise, and I think that's kind of where this bridge series is sort of melding these two things together. So we do those open procedures that we talk about. That's how we repair an aneurysm on the right side. We basically, like you were talking about, replace. We just sew in a whole new, because that aneurysm, you can't just repair it. That's sort of dilated and broken down, and it just needs a whole new replacement. But we do some other things too, like you see no right iliac artery, which is the artery in your pelvis that comes down from your aorta to your leg, and we can go through that and recreate a new one with stenting and kind of avoid a large operation in the right patient, and that's basically how it's done. But this is very important. So this seems a little too numberish maybe for our conversation, but I think it's really important because I'll have people come to me and say, well, yeah, I lived a bad life, but you're going to do a bypass on me, or you're going to put stents in my leg, and then I'm going to be fine, and it's going to be like new, and I'm going to go back, to what doesn't work that way. So this is in the best hands, and these are numbers that have been studied for probably the last 40 years. In the best hands, using vein, which brings the blood back to the heart, but it's the best conduit that we have. We turn it around and put it on your arteries to bypass around a blockage. There's a 75% patency rate at 5 years, so a quarter of them done in the best situations. And that's just from here to here, fem to above the knee. Only a quarter of them will be open in 5 years. And the further you go down, the lower that gets to when if you need to go to the tibial arteries, which are down here, you're only looking at about half of those are still open in 5 years. A lot of that's intimal hyperplasia. A lot of that is patients continuing to smoke, continuing not to exercise, et cetera, et cetera. If you have no vein, and a lot of times people do not have a large enough vein to make a good conduit, then we have to use prosthetic. Kind of the best one we have is PTFE, which is Gore, like Gore-Tex that you see in other products. They're an enormous company that's in medicine, but also in other areas, as you know. that's even more abysmal. So if you need to do a plastic or a PTFE bypass, an artificial bypass to the tibial arteries, not many of them are staying open for 5 years. So really the idea is to try to avoid this. That's the other thing that's on that website. If you read that, it says, they quoted some vascular surgeons saying, I spend about 80% of my time talking patients out of operations. Now stenting, well, we think it's great. It's minimally invasive. It's just a needle poke. We try to reopen that, this artery. We're speaking specifically about this one here in the thigh called the superficial femoral artery. That's the one that seems to accumulate the most disease and goes down the fastest. And only 90% of those are still open at 1 year. So it's worse than bypasses. Now, granted, it's minimally invasive, and a bypass is a lot of incisions sometimes, but very bad. So we have these things at our disposal. We really want to try to use them in life and limb saving situations. But what we need to do is attack the problem from the beginning.
I have a question. So
Yeah.
like 90% sounds pretty good to me.
At 1 year.
Oh, at 1 year.
At 1 year, yeah.
So like after 2 years.
It keeps kind of going down.
Okay.
Oh, and you have to like re-intervene, and then you sort of run out of options at a certain point.
Okay.
And the more it,
To a layman, I mean, I'm like, oh,
Yeah.
9 out of 10, that ain't bad, right?
right. But it is in a lot of ways, it's really a temporary fix.
So what's your second line of defense then? Like if one fails, what do you do next?
Well, you may be able to have a bypass after that. So you have that at your disposal, but sometimes you actually run out of options. And then you're talking about an amputation. The ischemia is that bad. So that's why it's almost like you kick the bucket over when you start intervening and set this clock ticking. So that actually leads into, you guys are very smart, by the way. That leads into our next set of slides. Just so we know the types of limb ischemia. So I think of them really in two major categories, but in three different ways. One is claudication. Claudication comes from the Latin, which means to limp, and it was actually first discovered in horses. They used to talk about lame horses, and when they became lame or they would limp, this is actually the reason why, blood vessels. So that sort of answers your question about other animals. It does happen. Now the nice thing about claudication, if there's anything nice about it, is that you're generally not at any higher risk of losing your leg than the general population. So let's presume all of us in this room have normal blood flow to our feet. If someone does not, but they only claudicate, which means they only limp after a certain period of time, their muscles get tired and cramp, they're not going to lose their leg at any greater rate than we are. So that's good. And that's sort of the problem in vascular surgery or other interventionalists who do vascular things like interventional radiology or cardiology. No one is probably better or worse than the other. But when we start intervening on this, then we start losing our options down the road. And that's like the last thing we want to do. And that's where you'll see where the exercise comes into play. But rest pain and tissue loss are, if you have those, your blood flow has gotten so bad that you are at a higher risk of losing your leg or kind of forced to intervene, especially on tissue loss. Those wounds won't heal. So this is a picture of one of my patients. So I don't mean to gross you guys out, but I think it's worth looking at. And you see this ulcer on the third toe. You see this ulceration on that toe. That is not from trauma. Those are simply ulcers that formed from bad blood flow. The blood flow is so bad that the skin in the feet cannot maintain its integrity like the way the rest of us. So if we bang our foot or we cut ourselves, assuming we all have normal blood flow to our feet, it's going to heal. These just kind of come out of nowhere. If we don't do something about that, they're going to lose their leg. So even if those things go down, 75% in 5 years, 90 in 1, at least we've given them some more time and we're justified in doing that. Some people are actually not active enough to know that they claudicate. So they don't even walk far enough to realize that they don't have good enough blood flow in their legs. I said it doesn't indicate that you're going to lose your legs at any higher rate but it is a high indicator of mortality. So if you have claudication, if you have blockages in your legs, you are at a higher risk of dying in the next 5 to 10 years. That's been shown over and over. And lifestyle modification is the first line therapy, not just for this, but for everything. I mean, remember, all of our blood vessels are kind of coming from the same place. So I'm sorry, this may be a little hard to see on this screen, but one of the ways that we figure out if people sort of have complaints about their legs, and they could be anything. They could be bad back, nerves coming out of your back. Some diabetics, their blood flow is actually okay, but their nerves are affected. The way we sort of suss that out outside of just a physical exam with your hands is we actually listen to Doppler signals and we take pressures on both the arms and the legs. And basically, your pressures in your ankles should equal the blood pressure that your doctor and your nurse gets in your arm. Once we start seeing that go down, so it should be in this range of 1. That's the ratio. They should equal. Once it comes down into the 0.5, 0.7, 0.8 range, you're probably someone who claudicates, who limps when they go a certain distance. When it gets down into the 0.3 or the 30% range, you're getting that rest pain, and when it gets lower than that, you're usually have tissue loss. And those are sort of the grades that we talk about. Diabetics are a little bit different, where they have inaccurate blood vessels. They tend to get a calcification on the outside of the wall, not within the wall. They have inaccurate, and it really starts to affect their small vessels first. So they may even have a palpable pulse in their foot. You can actually feel the blood flow, but then it goes off into sort of terrible small blood vessels that they end up having problems with their toes, and they're at a very high risk of losing their feet even in that situation.
Is that because the blood vessels that feed the artery wall get affected by diabetes?
It's probably because it's all small blood vessel stuff. So there's that, and then there's the small in the feet. And then the other thing that happens is having those high circulating sugars for so long actually deadens the nerves, so they can't feel. So they end up getting those malperforance ulcers, which you probably have heard of. They're wearing improper shoes. They're rubbing on it so much they don't even know they have that problem, and then until it's too late. So it's very sad what we end up seeing, where we're doing amputations on people who actually, on a macro level, have really good blood flow to their feet, and these diabetic patients, but these small vessels are really bad, and they're not going to heal. So if you go to this is sort of for many years has been our vascular text. I guess textbooks these days are kind of getting a little antiquated, but we still update them on a few year basis. But if you look at the last one, and I just picked a selection of articles. They're kind of old. Even the most recent one, which is really just a review article in the New England Journal, is from 18 years ago, and some of the studies on it are from even longer than that. So we're not putting a lot of stock into this. It's maybe kind of crazy.
Fam on 3. 1, 2, 3.